educational content by Dr. Mohammed Al-Naji Mohanar.
Hello and welcome. A sore throat is one of the most common things we see in primary care, right? So having a really solid, evidence-based approach is absolutely crucial. Not just for managing our patients well, but also if you're gearing up for specialty exams like the MRCGP AKT. So let's walk through the recommended clinical pathway.
Here's how we're going to break it down. We'll start with the initial diagnosis and management. Then we'll look at the specific NICE indications for when to actually prescribe antibiotics. After that, we'll dive into two key scoring systems, the CENTAUR and the fever pain scores, and we'll wrap up with the recommended antibiotic choices, a nice logical flow from start to finish. Right, let's start at the beginning. A patient walks in with a sore throat. What's our first move? What are the fundamentals we need to know? First off, let's just be clear on what we mean by sore throat. Clinically, it's really an umbrella term. It can cover pharyngitis, which is inflammation of the pharynx, tonsillitis, which is inflammation of the tonsils, or even laryngitis, involving the larynx. So the initial approach really hinges on your clinical judgment. The diagnosis is made based on the history and your examination. That's it. And this is a key point. We're not doing routine throat swabs or rapid antigen tests. It's just not recommended. So our primary management is all about symptomatic relief, advising simple things like paracetamol or ibuprofen to manage the pain. Okay, so if we start with just pain relief, the critical question then becomes, when should we even consider antibiotics? This is where the NICE guidelines are incredibly helpful and give us a really clear framework to follow. NICE actually gives us 5 specific criteria to think about. We need to ask ourselves, is the patient systemically unwell because of this sore throat? Do we see any signs of a more complicated infection, like unilateral peritonsillitis, a quinsy? We also have to look at their past medical history, specifically for a history of rheumatic fever. We also need to think about if the patient is in a high-risk group. Maybe they have diabetes or are immunocompromised. And finally, and this is a huge point for exams, we apply a clinical scoring system. Are there 3 or more CENTAUR criteria present? So let's zoom in on that scoring system. The CENTAUR score, what is it? Well, it's a validated clinical tool that's designed to help us estimate the probability that we're dealing with a Group A strep infection. The score is actually pretty simple to calculate. It's based on 4 clinical features, and you get 1 point for each. So number 1, is there tonsillar exudate when you look? Number 2, are there tender lymph nodes in the anterior cervical chain? 3, does the patient report a history of fever? And number 4, the absence of a cough, which kind of points away from a typical virus. The max score you can get is 4. And this table here really shows you why this score is so useful and why NICE set that threshold. If the score is 0, 1, or 2, the likelihood of it being strep is pretty low, somewhere between 3 and 17%. But look what happens when the score is 3 or 4. The probability jumps way up to between 32 and 56%. And that big jump in likelihood is what justifies even considering antibiotic therapy. But wait, CENTAUR isn't the only tool in our toolbox. There's also the fever pain score. It offers a slightly different, but just as valid way to assess the risk of a bacterial infection. This one uses the handy mnemonic fever APIN and has 5 criteria. Again, 1 point for each. So, F is for fever, over 38 degrees. P is for purulence, or that tonsillar exudate. A is for attending rapidly, so within 3 days of symptoms starting. I is for severely inflamed tonsils on exam. And N is for no cough or coryza, so no signs of a head cold. That gives us a 5-point scale. And just like the CENTAUR score, fever pain shows a really clear graded risk. A low score of 0 or 1 has a pretty low probability, 13 to 18%. But look at the other end of the scale. A score of 4 or 5 is associated with a 62 to 65% chance of it being strep. That's a very high probability, and it gives us a strong, evidence-based reason to prescribe antibiotics.
So you've assessed the patient, you've used one of the scoring systems, and you've decided that, yes, antibiotics are indicated. What do you prescribe? Let's cover that final step.
The guidance here is very specific, and this is a key learning point for exams. The first-line choice is phenoxymethylpenicillin. Now, if you have a patient with a confirmed penicillin allergy, the recommended alternative is a macrolide, specifically clarithromycin. It's a really clear 2-step prescribing pathway.
And that brings us to the end of our review. I think the big takeaway here is that consistently using validated scoring systems like CENTAUR and fever pain is just fundamental. It helps us move away from a purely subjective assessment to a more data-driven approach.
And that not only helps optimize outcomes for our patients, but it also supports the critical principles of good antibiotic stewardship.